Welcome to Health Law Talk, presented by Shahardy Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
And good morning, good afternoon, whenever you're listening to this. This is another edition of Health Law Talk here at Shahardy Sherman Williams, where we're bringing you the best in healthcare discussion, policy, regulation from the pinnacle here at Metairie, Louisiana, with myself, Conrad Meyer, the healthcare attorney, and my co-host, the ever-present, omniscient Rory Bellina.
Good afternoon, everyone. Good morning.
Good morning, good afternoon, right? And today we have a very special guest in the studio with us. We have Dr. Davida Packer. Davida, how are you?
Nervous.
You know, and really today is something very interesting that I think, you know, Davida, you brought to my attention and to Rory's attention about something that I think is really, you know, just starting to get discussed amongst physicians in a more open light, and a topic that I think is very, very timely and something that needs to be discussed about moral injury in healthcare and the moral dilemmas that physicians face when they get out of residency and they're in the world in healthcare. And I know that you had a very, very specific journey, and I know that your journey it's very personal. And so, when we talk about moral injury, and I didn't even know what that was, Rory.
I didn't either. I had to listen and actually read about it to see what that actually meant.
Right. I didn't know what that was. And
I didn't know what it was until she commented on my post.
Well, when you say we're going to get into that. So that's one thing that I think our listeners need to understand. What are we talking about here? So, with that being said, I want to turn it over to you, Davida. Okay, I want you to and try if I'm a resident about to go into the world of medicine, right? I'm leaving my trust tree of my residency program. My attending will no longer be there. I'm a PGY4. I'm looking at my contracts. I'm ready to go out in the world, and suddenly I'm faced with something I've never had to do before, and that's the business of healthcare. And how that might affect me as a practitioner, given that no one in my residency, no one in my med school has ever discussed with me the business of healthcare. So talk about that. What happens when physicians get out in the world, and you could share whatever you want to share about your journey. When you leave that trust tree and you get out in the business side, what happens?
I imagine panic for most people, and I think there is a push for residencies to start that training. Like when I was in residency here in New Orleans, we had university and we had Earl K. Long and we had UMC.
Right.
And so you had these hospitals that are not really where you practice when you're done, right? That is a weird model that is academic medicine. And some of the push towards the end of my residency was to get people out into the practices that are actually private practice and working. As residents, you don't really want to go there. They don't let you do anything. But you realize, that's actually how it is. And we weren't getting that training. And so a lot of people went out and just got slammed with the business. And you can't really do it on your own anymore. You can't put your shingle up and say, okay, orthopedics here. And so my background, I was a female orthopedist, not super common. There was definitely a push to be, tough and not complain.
Mm-hmm.
So even if I had the complaints, they probably wouldn't have come from me, right? Because there's like a bunch of dudes around. Can you guys complain for me? Because coming from me, I'm just whining.
Right.
Right. Okay. And I had an amazing group of guys, but did I really know what I was doing? And maybe some of it is just my personality. I kept stepping back and saying, maybe I don't. And that was in a lot of ways hard and hurtful. So I went, through medical school, into a residency program, came out, did a pediatric fellowship, came out, went into private practice in a smaller town in Florida.
Mm-hmm.
Some things that we're doing there were this is illegal. This is fraud with billing. But it was like, this is how you keep the lights on. Everybody does this. And I'm like, I just got like fully boarded credit. Like I know, these little kind of skirts to make sure that your billing works.
So let me ask you that. I'm going to interrupt. So when you say make the billing work, keep the lights on, and like who's telling you this?
Oh, well, the people that are.
Is it other doctors or is it administrators?
Both. It kind of depends on in what form. So in that situation that I was describing to you,
right.
That is in a private practice. I noticed that my signature was going out on PA visits.
Got it.
And I was like, I didn't see that person with that PA. Well, a PA visit bills at 80% of a physician. So it was just their habit to
generate that.
Them. Yeah, like an electronic signature.
Right.
And I'm like, but I didn't see them.
Right.
And so I brought it to the administration, to whoever in the office. And they were like, I don't know what to tell you. And then all of a sudden, I'm having a meeting with all the partners. And then the first time it was like, well, this is the way we've done it for years. And I'm like, well, we're not doing it with my name.
Right.
And then the second month, it was like, well, have you gotten over that yet? No, I haven't. I don't. I know I don't understand the business of it, but that's a lie. And I don't want to say I saw this person. What if something goes wrong? I don't. So I didn't want a part of it. Third month, they said, well, this is the practice. And I said, well, then I resign. And I did. And I walked.
3 months.
So you can imagine how that looks to anywhere else I try to get a job. Was
right.
Like, what's wrong with me, right? And I'm not going to be a whistleblower. It's way past. It's 10 years ago now. And so that next job was kind of hard to get, right? Because there's something wrong with me. I was out for 3 months and couldn't hack it. There was a lot of things that, I could kind of swing it and change it. I went from a small town to Miami. And so, I hated the small town. I'm from New Orleans. I couldn't stand it. People in Florida kind of knew this practice, knew some of the habits. But it was like, if I had kids that had started school, a husband that had a job,
right? How
do you just say, no, I quit?
You can't.
They're the only practice in town doing what I did.
So the stress, that obviously created a tremendous amount of stress.
Huge. And it was just, if I had moved an entire family with me, I probably would have just kept leading. Like, okay, well, all right, co-sign it, fine. What are you going to do, move your whole family again?
So that's where the moral injury comes in.
That's one of the first.
One of the first ones.
Yeah, it's.
And that's just one description of what one would look like.
For me, it was like that was not even 3 months out. I was already in a dilemma where I had to make a decision that would change my life. You either do this, or you have to bail, move, get a new job, sell your house that you just bought.
That's incredibly difficult.
It was insane, but they'd probably laid the platform for all the other insane things I've done since then. So,
well, so when you look at that, do you think what happened to you when you talk to other colleagues, because I know you have a lot of friends, was this an isolated incident, or do you think this is pervasive, systemic?
I think it's actually worse.
It's worse.
I think now, so if I think about when I graduated, the amount of people going into a private practice pretty soon, right? So almost everyone goes to fellowship. But then they may do another year or two in an academic type setting before they, are out in like a Pontchartrain ortho or Southern ortho, like somebody that...
Those are local groups here.
Local groups that are private, that are
right.
maybe affiliated with this hospital or that hospital, but they stand alone, right? They are not some big conglomerate under Ochsner or under LSU. And
for those who are listening, we're talking about a local market here in the New Orleans area. That's right.
And so, you go out but now the amount of people that go out to that type of practice where you are not covered by a big group, you're not an employee of a hospital system.
Right.
Those numbers are completely different. They flip-flopped. And part of that is because you can't really.
When you say numbers, I don't help me understand that. When you say the numbers of flip-flop, what does that mean?
I would say probably half, I don't know, 50, 60% of people went to private practice.
Okay.
Within a year or two of graduating from their fellowship. I
Okay.
would say now, maybe it's 20%
So where are they going?
into hospital employed positions.
Okay. And are you hearing from your colleagues that are either in private practice or hospital systems that the same sort of pressure on profits, money, revenue is always at front and center?
Absolutely. And enough people have had to sell their private practice to a hospital because they can't deal with they get boxed out, right? So if you're not going to be employed by the hospital,
Right.
then you can't operate here.
Why?
You're not an employee of the hospital. That's our new policy. And so, these huge hospital groups start, you no longer, and in some ways it allows them to control some things that are good, right? We're going to have quality measures. We want everyone to, we have to have call or whatever, but you can't have a private group. You can't have 3 private orthopedists operating at a large conglomerate. We want our doctors. And if you're not one of our doctors, then you can't use our facilities. And so where do they go? Now they have to have a surgery
You have to build
center.
a surgery center.
Right. So then where do you do, trauma surgery? Where do you do total hips that aren't going to be going home the same day?
Right. Where you need an overnight stay.
Yeah. So orthopedics wasn't designed for that kind of breakout. And that's what you see, plastic surgeons have. The ones that don't do reconstruction for like breast cancer, that's a separate world. But
Right.
like cosmetic surgery, it's all in a surgery center because they don't have to deal with the crap. They don't have to deal. They don't want to deal with the hospital.
So, and let's talk about the dynamic that we're talking about here, because we're talking about moral injury. So, tell our listeners, especially because we do have a lot of providers who listen to the show, and so I want to know what that looks like, because you're a doctor, you're a provider, and so even though you left, I get that, but you're in that mix for a very long time. What happened to you? Tell us, if you can, about. You talk about that one experience about the PA bills and the claims that you didn't see. Are there any others? And kind of walk our listeners through about that dilemma. What does it look like to you, and how the genesis of that?
Well, you can pick a day and there's a story. That's how
Okay.
bad it is. And I think that some of it is doctors are too tired to talk about it. Some is they're scared to talk about it. Mm-hmm. Some is a lot of people wouldn't listen. And I think COVID changed that now people just kind of realize that we're not this high and mighty looking down on everybody else and we think we're better than everyone else. And COVID really allowed doctors to become humans again. Like, we actually care what's happening to them and that they're working so hard and they're saving the planet, kind of thing. And so we were all of a sudden allowed to have feelings again. But this isn't new. I came out and was in practice for maybe 3 or 4 years before I realized, I cannot do this forever. I can't. And that's a hard thing to swallow when you have that much invested just time-wise. But I'm spending just so much time on the phone. There's an example that I think of it actually when I heard about this concept of moral injury was from a podcast that was sent to me about, just the moral crisis of doctors and what are doctors going through. And it was the first time I heard someone that was not a doctor actually have a clue. Was like, oh my God.
Are you referring to the Jonathan Shea article? It was in the New York Times a month ago? Okay.
Yeah,
That's
it's from this story of a woman named Wendy Dean who was looking at why doctors are committing suicide and at such alarming rates. And it's kind of spawned this conversation. Well, if you listen to what she had said about it and what he said about it, is that as soon as they, had a platform and started talking, all of a sudden all these doctors came out of the woodwork. They don't want to be on the record. They don't want their name. But they would tell the story. And it's like, well, why, though? Because there's some kind of, I don't know, it's like it's the in club. And if you are going to try to stand outside of it, it's so hard to try to change the culture that has been this way for so many years, and the people that are making money have so much more control. Like, did doctors let it slip away from them 20 years ago when we should have said, okay, we're not going to let anybody else manage us but us? Oh, that's another fight. I don't know how it started, but it took me a year to get a kid that has an unusual deformity in his leg, to get his brace covered, right? So over the course of his lifetime, we are going to lengthen his leg over a foot, right? One leg is way shorter. One of the things you have to do is you have to keep their foot flat on the ground while you're doing it, so that when you're trying to get the foot down, they're not stuck on their toes. So you need to be in a brace until we get there.
Okay.
Insurance company wouldn't prove it because it's an unusual AFO. Because he doesn't.
What is AFO? So we don't. Do you remember what that is?
Well, yeah, no. It's just it's an unusual brace that holds the foot up.
Got it.
And so
were they saying it was experimental?
No, they were saying that the special modifications weren't necessary.
Weren't medically necessary.
Right,
okay.
when you can get an off-the-shelf posterior splint.
I see.
Right, so these are like the hard splints that go on the back of your leg, just to hold your leg at a neutral position so you can't point your toes, right? So it goes around the back of your heel. And there are ones that are kind of, off the shelf.
Right.
This kid was born without a tibia. So he has not normal anatomy. There's no way that anything off the shelf is going to work. The biggest problem that I had with the insurance companies, they didn't know what any of the hemimilias were. Femoral, tibial, fibular hemimelia. They didn't know what it was. So he had tibial hemimelia. And at some point I remember on a recorded line saying, look it up on Google and call me back. And I hung up the phone. Because it was like, how are you going to tell me what's not indicated?
Right.
We are one of the only centers. So I worked for the Paley Institute in limb deformity. I was a pediatric orthopedist. And they also didn't know if they really were believing me. I'm like, well, while you're at it, Google me too, and then call my office and ask for Dr. Packer. It took a year to get that brace made. That cost, I don't know. I mean, it cost the patient $1,000, but in plastic, it was like 10 cents. And
when you say it took a year for the insurance company to approve or pre-auth the brace for that patient.
Right.
Okay.
So their surgery is now delayed because of this family. So when you're, part of my medicine, every corner of medicine has their little nuancy things, but they weren't from Florida. So these patients, when you're lengthening, they have to live at the facility. So one parent is with that kid in Florida, and the other parent's at home with the other kids in Wisconsin, wherever they are, right? And they're waiting and waiting. As soon as we get
for a whole year.
It took a year. And one of the nicest letters I ever got was thanking me for a brace.
When you're talking, I mean, that sounds extremely frustrating.
It was every day. Every day.
Who, on the other side, on the insurance side, who are you talking to? Is it some frontline rep? Was it ever another provider? Did they ever have another provider on the other end of the line on the insurance company, or was it only just reps?
You would have to get things escalated. So I would say, I mean, there's a reason why I know this language, and most doctors don't unless they are on the phone making the fight, which is I demand a peer-to-peer.
Oh.
Well, guess what? There's hard to get a peer-to-peer when no one else does limb deformity in the country but my practice.
So you're not even talking to someone with the same specialty. So it's like talking to apples and oranges here.
We just did our podcast last week. I don't know if it's been published yet, but the one on peer-to-peers in Louisiana.
Right.
The changes to that.
Correct. On the pre-auths.
Yes.
So we did one, and I know you don't know this, Davida, yet. I think we did publish it, but we'll see. Anyway, it came with a new legislation that came out in this session on new pre-authorization rules that requires peer-to-peer communication on pre-auths.
And it has to be someone in a
like field. Mm-hmm. In a like field. So you can no longer, if you're talking, as an orthopedic surgeon, right? You're not going to be talking to a podiatrist or a cardiologist. You're going to be talking to someone on a peer-to-peer level. But that is, and the patient's caught in the middle in this for the whole year.
And as soon as we get the go, so their finances are stripped to bare minimum. You've got one parent not working,
Right.
paying rent in a state they don't live in, just sitting and waiting for surgery while the other parent is managing however many other kids there are. You know what I mean? And it's like, and so then after clinic for 3 hours, I'm on the phone with this. And everyone wants to know why I didn't see more patients or why I didn't bill more, or why my records aren't complete. And it's just, I was like, I cannot do it.
That's got to be stressful.
You know, and to see, well, people that are cash pay get on the schedule first. This emergent thing has insurance problems. It's emergent.
Right.
I don't care. And I mean, and just everything, every little thing became that way, a fight. And
that wasn't an isolated incident. You're talking about other patients on insurance.
I mean, this was an everyday.
Okay.
One of the things, so I left the practice of medicine, 5 years ago, and went to law school because I knew I couldn't do that. But I was like, there's got to be some other way that I can change this. I've got to be a voice. One of the things, besides insurance companies, is lawyers. They change the way that doctors practice. And you guys, in general, doctors and lawyers just don't communicate well. They don't know the other's profession. They think they do. And there's so much miscommunication. And, I mean, you have, generally kind of type A people on both sides. They're both good at what they do. They did well in school. It's a similar personality. You don't really want to be schooled by someone else. And so the communication breakdown is just, I think, feeds it. And so you're documenting all this stuff because you're worried about getting sued. And all of that is not taking care of patients. You're documenting for the insurance company. You're documenting to make sure that the lawyers stay off your back. You're documenting to make sure that your administrator thinks that you saw enough patients today because you billed not a level 3, you billed a level 5 because you have the documentation to prove it, whether you did the work or not, right? If I did a level 5 work but only bill a 3, I still did level 5 work. I just don't feel like documenting up to a 5. And it's just...
Explain that so people understand what that means.
So...
For those of you
So in orthopedics, the joke is we're kind of dumb orthopods and all we care about is the bones. Well, mostly yes. And if you come in for a broken ankle, then that's all we do want to really take care of. I don't know. It's not part of your ankle treatment whether you had a cold or you have allergies or, just all of those questions they ask you, right? We all know what they are. You have this huge form. Does anybody in your family have heart disease, cancer? Like, not very much of that, especially in pediatrics, is going to change what I'm doing for your broken ankle. However, for me to get the full amount of a new visit, I have to have like 3 points of each one of those things, or 5 points of your past medical history, or, there's data points. They just want data to be able to say, we think that you did a 15-minute visit. We agree. And I care about 2 sentences that I actually wrote. And if you look at another orthopedist, if I send them the records, they're jumping down to where it's not the insurance documentation or the lawyer documentation. And it's like, well, that's 1 sentence or 2. Everything else is for someone else.
In the New York Times article that we referenced, that the moral crisis of American doctors, they talk about Dr. Shea, who kind of came up with these 3 criteria for what he defined as moral injury: when there's a betrayal of what's morally correct by someone who holds legitimate authority in a high-stakes situation. So for you, when did that moral injury start? Did you ever experience anything in med school or residency, or did it really start until after that? I'd love to know, when did the...
I would say, they give a great example in that, right? I mean, in that podcast, they talked about other people's first, experience with it. And I would say, no, I did experience it in residency, but you don't own it. And so your first year out from residency, they talk about first year jitters. It's like you think you know how to do everything, and you've been operating for years and you're great, and then there's no little bird on your shoulder saying yes, no, and now it's really your call. And when, for me as a surgeon, that's good enough, and I close up. Like, I don't want to keep operating and tweaking things. Like, I'm calling it, we're done, and close, right? The first time I can think of was near, I don't know that the very first one was actually the example I gave you in the first practice I went to, but that was the first one where I had to step out and say, I, Davida Packer, am making the choice because I am now attending, right? As a resident, I can think of things that were like, geez, if you got somebody else, you'd be in a better position. But, like, I'm not able to change that. I don't have control of it.
So I'm sorry, go ahead.
Yeah, I think that's the first, really for me would be once I wasn't attending. Like, the decision was solely mine.
When you were in med school or residency, when did it first start to be pressed upon you and your classmates about billing and patient encounter times and how quick you need to rotate through a schedule?
Never. Not once.
Okay. So that didn't start until you were out, and then all of a sudden it was told to you, here's your schedule of 60 patients that you're expected to see in 2 hours.
Correct. I mean, it started, like we were talking about, phasing in private practice training. So I think that's probably different for residents now. But it was something that the American Academy of Orthopedic Surgeons, everybody's academies were realizing, like, they're coming out and it's just like to a sledgehammer. I mean, you just had no idea.
Training on billing or EHR.
I mean,
coding.
well, so we went to Epic when I was I always say it was epic because it was. Being in a state hospital, they were going to pull funding. So we went to electronic medical record the last second they could. And so we had a certain amount of it, and some of it was the coders, right? So we weren't necessarily coding for billing purposes. We were coding to monitor our cases. So I did, 10 femur cases. I did 20 tibia cases, right? I need to be able to code that correctly for some other type of bean counting. But if you coded it wrong, then the coders, where I don't know where they were in the hospital, could actually, like,
some bunker somewhere.
They're in the basement.
Like, they got them in the bunker with no windows.
But they have, like, the red button, right, where it's like, don't let her practice anymore. She hasn't done her bills. And it's like, so you learn. It's like learn from being beaten, right? It's like you keep making my life more of a problem, more time consuming if I don't just use the code that you like, or use the modifier that you like, or make sure that I have these 5 points of whatever that up code. And it was just like, oh, God, I just want to take care of patients.
So there had to have been a moment, and I'm sorry if it's hard for you to remember, but there had to have been a moment when you realized this is not what I went to school for. Like, I went to school to learn and to treat patients, not to properly document to get the highest reimbursement and to churn patients as fast as possible. Did you have a moment like that where you really, like, turned your stomach and you thought, this is not what this is supposed to be?
Many. I don't know if there was one. I mean, that's the thing, is that it's so ingrained, and it's like, well, but who else is going to do this? This is the way medicine is. I mean, and I have really cool kids. My kids were awesome. And it's like,
how do you let that go? You can't let that go.
Can't
let it go.
Oh, I did.
And like,
well, you did. It's hard, right?
Eventually, I did. But
like you
they
mentioned,
beat it out of me.
You were so far in. You were, your 4 years of med school, residency, fellowship.
Two
fellowships, student loans. It just the whole thing.
It's like a trap.
You're so far in for you to get to the end, and you realize, wait a second, this isn't what I thought it was. But
where do I go?
I can't go backwards in time 10 years.
Right.
Well, and so when I saw this podcast, I mean, it really struck me. I don't know how to explain it other than I just felt motivated. When I left medicine, I wanted to do something to make it different that didn't destroy me. So I can't do this. I know I can't. But how can I make it better for the people that are willing to stay in? And I realized when I heard this podcast that, like, I haven't done anything towards that. Like, what am I doing to help people? And I still think, as part of where I landed, I defend good medicine. Like, stay away from good doctors. Bad doctors, get out. I think that's a whole nother issue that's part of this. But, like,
if there wasn't like a break fast moment, I mean, this is just built up over time.
Yeah, and it was like, where was that energy? But then also, why are people telling me I wish I would have? And I realized, like, when people ask me, why did you quit? There's a long answer. There's a very long answer. What's the short answer? Because I could.
Good.
I don't have kids.
Right.
I don't have a husband. I don't have a house. I don't have well, I do now. But, like, you know, at the time, I was still kind of like a resident where I could move and I could make a change. You
had the freedom.
And I don't know anyone else who has the experience. They gave medicine enough time, right, to say, I really can't do this, or it's really not what I thought it was. I kept thinking, oh, I'm in the wrong practice, or I'm in the wrong niche of ortho, or, you know, I'll just keep winding my way around until I find the perfect spot. Not many people at 36 can decide to go to law school.
What did your friends and classmates say when you made this decision?
Well, most of them didn't find out right away. Because I'm not embarrassed about it now, but I was then. It was quitting. It was defeat. It was, I can't handle it. It was a girl. We always knew she'd quit ortho. She's not tough enough. In some ways, I felt bad about. So ortho is a pretty sought after residency. It was like someone didn't get a spot because I got it. I bet that person's mad. You know, like, right. You got it and you didn't use it. You wasted it. But I still try to use it.
You're using it in a different way now.
Yeah, very different way now. And I think my relationship with doctors from a legal platform is completely different. I think they trust me more because I just tell them how it is. Like, come on, guys, we know.
Right.
I know, you know. And let me explain to you what's happening here, why you got brought into this suit, so that you're not an empty chair, which no doctor knows what that means. And they were like, oh, okay. Like, well, why have we never had this conversation? Why have we never talked about why things happen the way they happen in law? Because doctors don't have time. They're too busy.
I'm going to pivot for a second because we went back. You mentioned earlier, we talked about the insurance companies and getting pre-auths and the tremendous amount of time that took for patients. We've talked about the billing on the EMRs that you had to use to be able to get your highest reimbursement about the various levels of your E&M visits for your patients. Let's talk about how physicians are actually compensated. Okay, and I know Rory and I can talk about this because for years, I mean over a decade now at least, maybe more. I mean all of the I think you and I do. I mean I think together at least 20 or 30 contracts a year. You know,
absolutely. And
so all of our comp models that I know I have seen, and you and I've talked about this, it's always production based, and that's a move from
it gets to that.
It gets to that,
yes. But that's the end goal for most systems.
Correct.
I think.
Right.
Is to get to that production based model.
And what that looks like for the listeners out there, some sort of relative value unit, work relative value unit type base where if you're a new doc out of residency or fellowship, they'll start you on a guaranteed sort of like not to bait you. You got to start up. You have to build up your practice. So nobody has a practice when they walk out the door, right? When you get to your first job. And so to give you a base, they do a 2-year base usually, and then after the second year, then they switch you to this production model. And of course, they don't tell you in the base letter, and I'm talking about large systems. Groups are a little different because groups have a difficult time tracking RVUs. So they have, if you can find a group, if you can find a group that has the capacity to bring you in. But normally, like you said, Davida, you're going to a system. You're going to a hospital or you're going to a system, one of the two, right? 80% of the time. 20% you might get a group. But the WRVU contracts set a target value at some point in time later, and with a clawback. If you don't hit that target, then you get clawed back on your base. So it's a draw contract. Would you agree with that?
Yes. Yep.
And so now you've got back. I'm circling back to Davida. Now you've got another layer of competition. You follow me? So now you've got, in addition to the pre-auths that you got to get approved, in addition to all of the challenges you're facing now from a business standpoint of coding levels in your records, that coding level requirement is a target that you have to meet in your compensation contract, or you get clawed back.
Yeah, well, so
did you see that in your practice, and have you heard about that? I'm just curious.
Yeah.
Tell me about what that means to you.
We had that
was a long way around the barn.
well, first, because I was getting stuck a little bit on figuring out the pre-auth and the billing, coding things.
Right.
You're talking about just with a hospital. But
well, a hospital, but also the employees. Some employers that track RVUs, but I guess my point is that when you start bringing all of the things together, like the pre-auths with insurance companies, the E&M visit coding level, so you get that higher level reimbursement that you have to talk about the things you don't really even care about, to now your overall contract with the group or that system requires you at some very near point in time to reach a certain RVU level, or you get clawed back. So in your mind,
it's always there.
Where is the moral issue? Now you're seeing patients to push things because if I don't do this, I'm not going to reach my target. So, have you heard about that with your?
I've had it happen.
Well, tell us about that.
So one of the things is that you're not only working on pre-auths just for surgery.
Right.
It's also to get an MRI or to get a brace or to get their medication. So those are 4 different entities. One doesn't fix the others. Right. And so a minor problem in coding, which I think I should code it as A. The coders think it should be B. Well, that sets off a whole different problem of if I shut them up by giving them the code they want, now the brace company is going to decline it, or I can't get the MRI, or I can't get a CT because some other box checked put it down a different. So I mean, it's huge how much those things are, and each entity doesn't talk to each other. So just because I got your surgery approved doesn't mean your brace was approved or your medications afterwards. 3 different people. So after I get through all of that, I'd get a call from admin saying your numbers are low.
Like your RVU numbers are low.
And it's like I'm new.
Right.
And I'm what you're saying, I'm salaried. But I'm trying to build a practice, I'm trying to learn. I've got these old guys around me that know how to do everything. So if I had downtime, I would go operate with a guy that's been operating for 50 years. And I can't bill for that. There's no RVUs. So it looks like I've been sitting on my butt, and admin wants to know why my numbers are low.
How frustrating is that?
It was just infuriating.
So
if I tell them to buzz off.
What do you do?
What do you do?
I mean, beat your head against your desk. I mean, what can you do?
Is this the problem that we just described, with the RVU, chasing the RVU? I'm going to call that the chasing the RVU, right? How prevalent is that?
It's been prevalent. So
for how long?
I went to, I would say, I guess that was 2013, 2014.
Yeah.
That a practice that I was joining was, there's big conglomerates taking over and the bean counters are watching, and there was an older spine surgeon that was just a guru, right? I mean, he would just, to get everyone to leave him alone, he would just bill a level 1 because he doesn't want to learn electronic medical records. He wants to just take care of patients. He wants to write his notes. And he would put something in an electronic medical record that would equal like a 1, right?
Which is the lowest form of
lowest form that you could bill. Basically, I'm not doing anything but check a box. There's something here.
Okay.
And so admin caught on to it. They were like, you have to start billing appropriately. And he said, well, I'm not going to. I'm going to take care of patients. And if you want to have something like a scribe or somebody with me that wants to learn all that, that's fine. But I cannot take care of people the way I take care of them. And that at my numbers, right? At seeing 15 people in the morning and 15 in the afternoon when they're spine patients.
What happened to him?
He quit.
Wow.
They said, do it or get out.
So that's the push coming from administration.
In 2014.
And it's got to, you think it's still going on today?
I think it was in its infancy then.
You think it's everywhere?
The people that were like him, that were from a generation that didn't have electronic medical record, that didn't have RVUs, that didn't have all this, very few are left practicing because they did. They finally just said, I'll wash my hands of it and I'll leave. Well, I mean, I can recently think of a problem that occurred that if they would have had an old surgeon around, somebody that knew how to practice before Epic told you what you needed to do, right? There's all these warnings and medication,
And you're talking about the medical record itself. It flags you with warnings.
So it's not necessarily Epic the brand, but
not Epic, but the medical record can flag it.
Right, and it it's artificial intelligence. It can make connections that you may not be making. It can.
So now we have medical records practicing medicine, right? Is that right, Rory? You got AI like Chat medical record, Chat GPT medical record. Gosh, bless.
They're pretty impressive on like what they can flag and catch.
Well, that also goes back to, and I'm cutting you off a little bit on the EMR side, because on Epic I know about templates, and all of us heard about templates over here on the lawyer side. I've seen it, and I know you've seen it. Another method of efficiency to not get bogged down in the medical record, but still cover your bases. How is that? And I'm going to get back to the RVU thing, but let me stop that.
That covers your RVUs.
That covers your RVU thing.
The template covers your RVUs. That's why they're so prevalent. But that is another reason I feel like as a lawyer I can read records really
problematic.
fast.
I mean, problematic, huh?
It is. Oh, I can read records really fast because I know where templating is and where it isn't.
On the review of systems.
And so
just cut and paste.
Yeah, I can jump in to a medical record and see what the doctor actually wrote in pretty quickly and ignore templates because I made them for myself. I know how they work. And so I can just blah, 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 blah. Oh, right there. This one sentence is the meat.
So back to RVU. So you think that this RVU, chasing the RVU for physicians is systemic and it's everywhere?
Oh, it's everywhere.
What have you heard from your colleagues that will even talk about this regarding how this relates to their moral decision-making for patients?
I mean, they'll talk about it to me, but they're not going to talk about it in public because...
What does that look like?
I can...
or sound like?
It sounds like defeat. It sounds like I want to help people, but I can't. And I can tell you there's people in this community that we're sitting in right now that are on the fence, that they're trying to figure out, how can I help people but not have to make a living doing this? How can I make a living doing something else and then do orthopedics on the side because I can't?
Do you think that's going on right now, even in the New Orleans area?
I can tell you it is.
So if it's in here, it's all over the country.
It's everywhere.
Oh, wow.
I think just COVID allowed doctors to maybe be a little human. I mean, people think oh, you make so much money and you're just complaining. No, really, no one does.
Well, let me hit that for a second. The money. I hear that too. I mean, Rory and I have talked about that in the past, the perception of people.
Yeah.
And surgeons, or I'll just use orthopedics as an example. They make $600,000, $700,000, $800,000, $500,000. That's a lot of money. Given that, and all the things that we talked about here, and we haven't even touched private equity yet. I mean, we haven't even got to that, which is on our side. We've seen that as a boon in the last 5 years, I would say, or more. So given the issue or the perception of the public that these physicians, whether specialists or not, make a tremendous amount of money, more so than the general public, do you think physicians, if you could wave a magic wand, right? Because we talk about how do we cure this. What if the magic wand said, you're not gonna get paid $500,000, $600,000, $700,000. Let's pay you $300,000, but you're not gonna have to code and do all these unnecessary. You can see patients again. Do you think it would be a reimbursement? Do you think people would be like, you know what? If you cut the red tape,
I'd go back.
I'd go back. You think that would cut the stress, even if they made less money but less headache?
Most people would take it.
Really?
I mean, it was not.
Wow.
If you didn't go into this for money, you didn't. And you guys write contracts. When's the last time you wrote a contract for $500,000 for an orthopod?
Easily. I thought easily.
Not spine.
No, not spine?
Yeah.
No, not spine.
Now we're just a regular orthopod. Well, get down to the,
No, I mean, the spine is different. I'm talking about an employed orthopod on a spine, back spine. I agree.
Okay, so what about, an employed
hand?
Pediatric orthopedist?
Oh.
I know of a few, but they're in systems.
They're in systems. Everybody's in systems.
Well,
so no more, right.
So pediatric, you kind of have to be. So I want to take care of kids. Kids don't have great insurance.
Yeah.
Sometimes they do.
Yeah.
Mostly they don't.
Right.
But you're most likely going to tie yourself to a pediatric system.
So I can tell you the offers are in the 200s.
Right.
You think that they are all of a sudden tripling within 10 years?
No.
So, okay, 200, let's be real. 200 a year is not a bad salary.
No.
But so let's figure out what's an equal salary. Should it be equal to what you owe in debt?
No, I guess the thing I was thinking of, it was the choice, right? Rory, and you and I have talked about this in the past in Davida. I'm going to share this with you, but the choice. In other words, if we could wave a magic wand, kind of like what the government did with COVID and telemedicine, Rory and I in the background have watched telemedicine regulation evolve literally over years.
Yeah.
And the infighting between various groups about how to bill, what to see, distant site, originating site, all those factors, right? And when COVID hit, within 5 days, it was gone.
Yeah.
Gone in 5 days. So
magical.
It was like a gift, right? And so now I'm looking at the physician moral injury, because we haven't even hit PE yet, private equity yet. And if we could wave a magic wand and say, doctor, you will not have to sit on the phone for hours on pre-op. You will no longer have to do a specific amount of data points for E&M coding. However, you could spend more than 6.5 minutes with a patient, be able to talk to them. However, your reimbursement on your personal level is going to be cut 40 to 50%, but you'll have no more red tape. What do you think would happen?
I'd walk back into practice.
How do you think physicians would accept that, or would they accept that?
Almost. I mean, there's always going to be somebody that wants money, right? But when you take why did you go to med school? Why did you go into this? Why are you here? I want to help people. If you said, do you want to just help people for less money and not deal with all the bullshit? I don't know any doctor that wouldn't literally sign right there. I don't even need to hear anymore. No, we don't need to figure out. We don't need to go back and forth and jockey agreements.
Right.
Sign here. Done. Go.
Interesting.
Take it.
That's a very interesting thing.
So when I've talked to people on the insurance side, and I've obviously talked to a lot of providers, and they both kind of point the finger at each other.
They do.
The insurance companies will say, well, we have to constantly adjust our reimbursement rates because things are changing, costs are going up, costs are going down. Doctors should be more efficient in completing procedures with robotics. And then physicians will say, well, we're having to change our practice schedule and style because of the reimbursement rates. So there's just this never-ending kind of loop of fingers being pointed back and forth at each other. What's your take on that when you practice? Was it your system or your admins that you were in, or do you think it's the insurance industry?
I don't know if there's one. I mean, I think that each one is capitalized on the other, right? And some of that is law too. I mean, there's a certain amount of CYA in every chart that is not really for the insurance company. It's not for the patient. It's not for me to talk to another doctor about. This is for me to cover my ass so I don't get sued because I didn't say whatever. So there's that piece of it too. And so one of the things and why I don't feel like I abandoned medicine. So my concern, very back in the beginning, you asked me, what did other people think when I did this? I was very concerned that people would think I was a traitor, or I don't even know the right word for it, but just ugh.
And then you became a lawyer, which is worse.
And then I became a plaintiff lawyer.
Oh, we were going to bring that up.
Wow.
And so that was, that was kind of, I figured, the last stab of any friendships still existing.
Right.
But I was very lucky to end up in a firm that only takes good cases. And seeing that, I'm like, I think this is how it started, actually, was we won't throw out our dirty laundry. We won't say this doctor is bad. And there's not a lot of documentation. So with lawsuits, now you have to start documenting more and documenting more. And then the insurance companies figure out how to tag that and make it that we need this amount of documentation to be X amount of dollars. And so the two of them just fed off each other. And doctors let it happen. But if you would have said, this guy's bad, and forced him out, would lawyers have gotten the ground they got in getting documentation, right? And getting you to document 4,000 things, because otherwise you're going to be sued. Well, you set up that platform for insurance to come in and make a template off of it. Oh, he skipped A, B, and C. Level 1. You know, and I'm like, and so you see this kind of feed of like, so if when malpractice occurs and you do have a bad doctor, if they would have just said he's bad and get out, would we have gotten here? And that's the only way I can chicken or egg it. I have no idea who came first, but everybody's
so let me
lily padding each other.
Well, let me just tell you this. So now I'm going to get into PE, because in the last, I think I would say 5 to 7 years, Rory, is that accurate? You know, even pre-COVID, we've seen an influx of private equity. You already had the issue that, and you brought it up about no more, you know, very hard to go into a private group, even at family at the gatekeeper level, right?
I mean, how many small dentists do you see?
You don't see anybody.
Right.
Very, very few. The dentists may be a little different, but I think on primary care physicians, I mean, I don't know about you, Rory. I don't know any solo groups on PCPs at all. Everything's now in a system. All of them are, at least in our market, right? And so there's nothing left. And so now PE comes in, private equity, and they start looking at the more lucrative practices to buy up because they want to get in on the healthcare market, okay? And so, you know, we've done several PE deals. I know you have, I have, people in our firm have. And when the deal with the PE firms is because they're private equity and not another provider, they can come in and offer a multiple on the business at a much higher level to entice these older physicians who want to retire. Okay, let me go ahead and take my pot of gold now, and then leave the younger docs to deal with the administrative levels of private equity. Do you know, and Davida, this is I guess I'm going to ask you this, do you know any colleagues that are currently in private equity arrangements? And if so, and what has their experience been pre-private equity, post-private equity?
I can think of one that was in private practice and came out into, a private equity situation.
Right. What was that like?
Miserable. And it was like, I'm either going to go back to private practice or I'm going to quit.
What happened? Can you? Do you have any detail? If you don't know,
yeah, some of it is. But I mean, it's a common
it's the same
thread.
thing.
It's the same thread of like.
Right.
So people, when you were in private practice, you had some control over how you see things when you see them. That in pediatrics, for example, one of the quick in my world, a quick turnaround is people that are in towing. Right, your little girls walking with their toes pointed in. You just grow up and get over it. And especially in some communities, they still think you need to wear braces, and so they would put like 15 of these appointments on. For me, that's frustrating because I'm not doing any orthopedics. But if I bring a case on of tibial hemimelia, I'm going to be in that room for an hour. It is the same billing. And so people that are in private practice can make that choice. No, I'm going to take an hour to see this patient, and I'm going to bill this, whatever. I mean, like, this is what I went into this for. When you go into, the big machine, when you go into the Walmart of medicine, they're like, nope, we're going to do 15, one, let's say you get 1 point for each. One, you get 15, one, you get 1. You have to go do the 15. No. Yes. Well, I don't schedule, right? I'm not the scheduler.
Right.
So how does that happen? Well, they just change the people that answer the phones. You only get certain things funneled your direction.
So let me ask you this. I'm going to say a statement. And Rory, I'm looking at you and I'm looking at Davida. And I want you to know, what do you think when I say this? In today's healthcare delivery systems, medical physicians have full autonomous medical decision making. Do you agree or disagree?
I 1000% disagree. They do.
That's scary.
So they do. They have brains. They have a thought.
Right.
It's not what they get to do.
Because of these external factors.
Right.
Who's talking about this?
No one.
Wow.
Which is, so when I saw that post, when I saw this podcast, I was like, why am I not doing anything? And so I put a post up. And you know, there are people that have wondered why I didn't quit. I've never been able to put it into words. Here, listen to this. This is it. This is scratching the surface. And I quit 5 years ago. So, like, the amount of people that came out of the woodwork and were like, thank you. If you figure out what's next, I want to help. Great. You want them to know your name? I don't know yet. Well, no one's going to hurt me now. I don't practice medicine anymore. So I can't get forced out, or my call schedule is all of a sudden terrible, or I can't get an OR schedule, or the people that are calling in to schedule, you know, you call for an orthopedics appointment. The good cases, where do they get funneled to? Well, when it's not causing problems.
So, and I'm looking for a legal answer here in a discussion, Rory and Davida. One of the things that Louisiana has done, and it's going on across the country, is direct care models. Okay, and I don't know people know what that means. It's like imagine concierge, MD VIP, things like that. And I know what that's going to spur. They're going to say, well, you know, it's you know, for the haves and the have-not, there's a disparity there. Now, direct care model is different. The issue that I've seen, this is a systemic, multifaceted issue. You got insurance companies who now have been collecting more data points because of defensive medicine tactics by physicians, who then have to document tremendous amounts to cover themselves for liability purposes, where insurance companies now say, we're not going to reimburse you until you cover these data points because now you've told us what it is, right? And then you've got, you know, administrators and private equity who's saying, in order to keep our lights on, because of the decreasing reimbursement, you need to chase the RVU like never before, regardless of your moral compass as to your duty to patients, right, that you took, right? What if, and I mentioned whether it's pharmacy or DME, you know, we can talk about that, but and I asked you about, you know, could we just cut the red tape, and would physicians accept that if they could actually see patients? And the answer was yes. So here it is. Direct care model. And what the issue was because if you tried to do direct care with patients, the state regulatory, and this is where lawyers come in, would come in, and the DOI, the Department of Insurance, would say, well, no, doctors, you can't do that kind of model because you're acting like an insurance company, so you can't do that. They have now cut regulation, and I think it's over 20 states now. And I've read Louisiana's direct care statute and statutes, and it basically allows more focused on primary care. But I'm wondering, could you apply this to other specialty practices? I mean, is it worth it, given the state of reimbursement, to where you can contract directly with patients to pay a per member per month rate? And for that, you enunciate all of the services they get. You know, here's what you're going to get. You know, and we will never bill insurance. We will never bill them. You just come in. We'll give you, you know, expedited appointment. We cut the red tape. We're going to document it, but no claims will ever be filed. Have you heard of that?
I heard of it. What bothers me about it is, like, you're not a Chevy, right? I mean, the amount of things that don't fit into a box,
right,
in a human.
Okay. It's
not like you have a contractor and you're okay, for 6 years we'll fix whatever goes wrong with your car. Well, that can be a huge amount of things.
Sure.
And when you're in that model, right? So the problem is, okay, let's say I'm internal medicine and I've got exactly what you're saying. Well, the practice brings in $100,000. If I spend a lot trying to chase something that might not be your problem, but I don't know, I'm going to get an MRI, I'm going to do all of this stuff, and I'm whittling away, right? It stops you from wanting to do that, because then your lights aren't on for all these other people you're supposed to take care of.
So it's a capitation model that I'm kind of referring to. It's a capitation model. So that in and of itself is not going to work, because then you're sort of limiting the care given your member per month and the size of your panel.
Right.
So you need, so kind of like some
it's also
homeowners.
medicine specific, right?
Well,
how
I
do you do it
am,
for ortho?
and I'm saying that. So right now, I'm a kind of equating this to homeowner insurance right now, because in Louisiana, I mean, we're in a crisis mode, right?
Right.
Nobody wants to write, and so my point is what about having a direct care model, but then having a higher level of catastrophic coverage that covers that? And then are we just back to the same model? Okay, well, fine, we have a baseline model, but then the risks associated that you're saying aren't going to fit in that capitated model. You have a higher deductible type policy. Does that? And the bell's going off because we hit an hour, right?
I
mean,
think,
you see what I'm saying? I mean, I'm trying to solve it, see if I can solve an issue, and I don't know if it's solvable because there's so many facets.
I think of that as a consumer, though, is you're back to the insurance model.
You're back to the insurance.
You're
right.
not, as great as it would be, like you said, to have the membership, and that includes everything.
Right.
Just like Davida mentioned, at some point, if you got something really going on with you,
Right.
that doctor's going to say, look, I've done everything I can. You're going to have to go to a system now.
I'm
And
handcuffed.
and what do you do if you canceled your insurance?
So one
Right.
thing, just to throw a wrench in how you're thinking about that, is when I was in California for fellowship, that is somewhat the model they are doing to work around horrible healthcare. And what it is that in California, if you want to see any doctor that's worth seeing for dermatology, I mean, even internal medicine, rheumatology, these things are not emergent. It's cash pay. You can fight with your insurance company. You can do the billing. They don't. So it's like, yeah, we might not get as many patients because they don't want to do it themselves or they can't afford to do it themselves. I don't care. I don't want to do it. So I don't. You do it. Our fee is $200. And so, but then, so people that are essentially wealthy just pick the doctors they want, pay cash they want, and they carry a catastrophic plan only for car accidents, essentially. So it's like, if I get into a major car accident and I'm taken to UCLA, I have coverage for that. Everything else I pay cash for.
Well, then you get into the haves and the have-nots.
And so, but who else can do that? Right?
Not many people.
Right.
You're talking about the top.
But that, I mean, if you had every option in the world, how do you deal with it? That's how you deal with it. How do you make doctors want to show up for work every day? Ask the people that are in that platform, which are cash pay doctors that have, what have they done to be cash pay? They got rid of all the insurance paperwork crap.
It's interesting. I mean, I guess, when you're looking at it.
Why do I have to do all that?
I want happy doctors. And you know what? As a patient, and from the consumer standpoint, Rory, when I go into my physicians, and it's so funny because people call me and say, oh, I went to an orthopedic surgeon, and they told me that I'm going to have to get cut. And I'm like, well, I don't know if I really need to get cut. But they told me I had to get cut. I said, well, you went to a cutter. I mean, you went to someone whose job is to cut. So, of course, they're going to say, well, you need to get cut. My in the back of my brain, knowing all of the stuff we talked about, because I think that nobody's talking about this. Nobody. Our doctors, is the moral injury, the moral dilemma that we're talking about, is the lack of true autonomy and control for their patients.
So next time you see, I'll leave you with this.
What's that?
Next time you see a note from a primary care doctor, because you get them, we all see, 4 pages now at least? 3 pages? Like,
yeah.
What's a small note? Take a Sharpie, cross out everything that is for billing or for a lawyer.
Oh.
And tell me what's left and how much time it would have taken to write that, if that's all I had to write.
I think the impression.
It's it.
The impression would be the only thing left.
So you could, if you
the initial complaint, right? The review
here
of
for broken ankle, put in cast. Love Davida.
Right.
So if I was a cash pay person, why would I need to document any of that?
Professional liability purposes was the only thing I could think of.
The only thing I need to document is the orthopedist, the actual things I care about.
Right.
Non-operative fracture, X-rays look good. Maintained in cast, follow up 2 weeks.
How would you, if you could wave a magic wand? I've given my thought. You're the physician. I'm not the physician. You've seen this. You've dealt with this. You talked about this. We've gone over a lot of different things that are controlling doctors' minds and practice patterns, literally. What would you do?
I don't know. I don't think there's a solution at this point. And part of the reason I walked away was because I cannot do this. I cannot practice medicine this way. I will find another way to help you guys. I'll be back when I do. I don't know.
Wow.
I think it has to implode. I mean, there's so
What does
many-
that look like?
COVID. If COVID would have lasted for another year, we might have seen our healthcare figure itself out. It didn't last long enough. But how many people quit? I mean, right now,
I don't know.
right now in our town, getting an MRI or a CT or an X-ray outpatient, right? Not in the hospital, but if you just go to a freestanding facility, it's taking a week. There's not enough radiologists reading. Why? Because they don't want to. No one wants to do this anymore. It's painful. They're getting sued. They didn't document enough. They didn't bill enough. It wasn't coded correctly. It wasn't whatever. It's just not worth it. I'll do something else. And when it almost killed me to go every day and people were making comments like, well, it's the profession you chose. Okay, I'll choose different.
And you did.
And for me, it was before COVID. But, I mean, there is no way I would have made it through the COVID. You know, just how there's a lot of people that gain respect, but there was a lot of people that said, well, you chose to be a nurse or you chose to be a doctor.
Yeah, I mean, we get that too. I mean, because you have student loans. Most doctors have student loans, right? Most lawyers have. All of us have student loans. I mean, you're kind of, and if you leave the profession, what else can you do to because those loans aren't dischargeable in bankruptcy. They stay with you until you die.
I still owe $180,000.
Oh my gosh! So, wow.
So how do you do that with kids
I don't know.
a house and I did this. I walked because I could.
This is the moral injury we're talking about.
Yeah.
Wow.
Can you imagine what my life would be like if I didn't? You know, I mean, it's like, I don't know how people go home and still like their kids at the end of the day. Like, it's just everybody's whining about something, and then you go home and they're actually too and allowed to whine. But,
Right.
like, you've heard it all day. It's like, how do marriages survive? How do kids grow up happy and healthy? Do you ever see a baseball game? Like, no, you're not. You're not there.
That's
unless you're a
sad.
shift worker.
That's sad. Any thoughts, Rory? I mean, I don't want to keep.
I don't know. Yeah, I don't know what the
I'm just like, I got a cloud of questions. I'm like, how do we solve the problem? Definitely A plus B does not equal C here. You know, we're just not, you know, I feel like we're putting a square peg in a round hole and trying to jam it through. I mean, I think, and so what, I know you know a lot of colleagues that are like struggling internally with this. I mean, I can't imagine they're talking to their partners or, you know, I mean, this is just an internal stress bomb.
It is, and the other problem is, when do you have time to sit and talk about it? Because it is such a big problem. And you already have negative time. So you have a problem you don't have a solution to, that nobody has a solution to, no one's talking about. It's so complex, there's no way that one conversation fixes it. Do you start that?
Right. No, we're not
When
going
you're
to.
already just like pulling your own hair out
Right.
to make it to your kid's birthday?
Oh.
You
Well-
just can't. I mean, don't even let yourself think it, because I cannot go down it.
Well, let me just say this. I want to, first off, Rory and I want to thank you profusely. I've known you for a long time. I thank you for coming and talking about this, because it's not easy, and I really want to thank you for that. And I know our listeners, when they hear this, it might strike a chord with them, and so I know they will thank you. And I know you're right. This is not a one conversation deal, and so I would like to bring you back to talk about this further. You know, because I think it is an extremely important topic that no one talks about, that I know Rory and I see on a daily basis from the legal standpoint, from various perches. And you know what? I want to when I hear listeners, I want y'all, the listeners here who are providers, anybody who's listening to this, anybody who this struck a chord with, I would love for you to contact Rory or myself. Okay? Because I would love if you want to talk about it, whether you want to come on the show or not.
Or
Okay.
contact me.
Or contact Davida. So with that said, Davida, would you feel comfortable giving your email address out, or
It's
does that?
very easy? DavidaPacker@gmail.
There we go.
So,
And then
I mean, some of it is knowing how to. I would never, and I've tried to be very careful not to let any of the friends that do confide in me, their kind of story get out in a way that anybody would know is them. But I get it, and I don't have to be scared anymore. No one can hurt me. So I can speak. Tell me your story.
right.
And let me figure out a way to do something with it. That is what I left medicine for. I haven't found exactly the way back yet. I don't know the fix, and I still don't know how I'm going to participate in the fix, but I'm trying.
Well, let me say this: if you, for those listening who are providers that would want to talk to Davida, she gave her email. We would love to talk to you, even if you don't want to come on the show, just to talk to you about this. You can reach me in my email, cm like Charlie Michael @shahardy.com, and Rory, yours is
Bellina, Bellina.
@shahardy.com. We really think this is an important issue. We would love to hear from you. Please do not be shy. If you hear this and you've gotten this far, because this is probably one of the longest episodes we did, we would welcome you to send us an email to talk to us about that. And if you do want to come on the show to talk about your issue and what you're seeing, we would welcome that, because I think a lot of providers, we have reached a lot of providers here. I think this is a lot more common than what's being discussed. I think Davida has shown that. I know, Rory, you have shown that. We've discussed it. So please feel free to reach out to us and come on the show. Davida, thank you so much.
Yes, thank you.
I mean, this has been
great.
fantastic.
Sorry for just yapping away about it.
No, not at all. We really appreciate that. And for those of you who are listening, thank you for joining us for another episode of Health Law Talk. We at Shahardy Sherman really thank you for the opportunity to bring you the latest and greatest in healthcare policy, social issues, regulatory compliance, transactional, and you name it, we bring it to you. Look forward to hearing from you. Y'all have a great day. Enjoy.
Thanks for listening to this episode of Health Law Talk, presented by Shahardy Sherman Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Shahardy Sherman Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Shahardy Sherman Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.